Good afternoon, everyone, and welcome to the Board of Pharmacy's webinar today. I'm Tom Glinsky, the Chief Inspector with the board. Our guest today is Michael Boger. He's the administrator at the Bureau of Narcotics and Dangerous Drugs. Thanks, Michael, for coming today and giving us a presentation. Before we get started, I'm going to just go over some general slides, and then I'll turn it over to Mike. If you haven't been on one of our webinars before, you're in listen-only mode. If you have any issues with sound, you can go to the toolbar and change from computer audio to phone call and dial in if you're having any issues with computer audio. This has been approved for 1 hour of CE. You must be logged in to GoToWebinar as an individual user in order to get CE. I will go over more instructions at the end of the webinar on how to obtain it. A reminder, we do not submit to the CPE monitor, so it's important that you save your certificates that we will send you. Handouts are in two places. You can find them on the board's website under the upcoming events tab on the left side of the website. Then that'll take you to the sign up page that has the handouts listed, a link underneath that. They're also on your GoToWebinar toolbar. If you can see on the screen, if you open up the handout section, you will see a handout there that you can click on and open up. We record all our webinars and post them on our website in case anyone misses it or you want to go back and listen to something. We asked, we will be able to send questions in. However, we did ask for questions in advance and we're going to take those first. And we did get a lot of questions in advance, so we're going to start with those. But feel free to send a question to us. If you haven't done that before, go to the toolbar, type it in, and just hit send. And at the end of the program, we will see if we can get to those. So now I'm going to turn it over to Mike.
Thank you very much for having the BNDD in today to participate in the webinar. We've been looking forward to doing this. We've been working on it for a while and got everything ready to go back early in March. But as you know, due to recent times, we've been postponed and we're all dealing with other current events right now. So some of the slides that we're going to go through are issues we wanted to cover that we get the most emails and phone calls about. I want to fly through them rather quickly because this was prepared back in early March and it's just a quick review. And then I want to spend a lot more time on answering the current questions that everybody has. But I just want to thank the board and everybody for letting us participate today. I have a disclosure notice. I'm an employee of the Department of Health and Senior Services and the BNDD. Our Bureau does not have any financial relationships with any entity in the medical or pharmaceutical industry. We do not accept any honoraria or things like that when we do our educational presentations, and we do not discuss off-label or investigational uses in our presentations or anything like that. I want to talk a little bit about the status of some pending legislation that was going on, and the session just ended last Friday. So now there are bills on the governor's desk for the governor to sign or veto. He can take up into the month of July to do that. So we'll find out what is signed and what is not. In these cases, whatever is signed into law goes into effect on August 28th of 2020. So we'll have some window of opportunity to prepare for those things. But right now, we're kind of getting our head around everything that passed and did not pass because they combined a lot of bills during the last week of session. I'm going to go over some hot topic issues that doctors and pharmacists are calling in about, and then some things that the BNDD is working on in the future, some changes that we're making to better serve everyone. Legislation update. Last year, The General Assembly passed that law stating that all controlled substance prescriptions must be electronic by January 2021. That has not been funded. So the ability to make everybody go electronic, have a regulation in place that's set up, a database or a way for pharmacists to know who's allowed to electronically prescribe or not. There's about 8 paragraphs of exemptions. Pharmacists are want to know who's exempt and who's not. Doctors can apply for an exemption. None of that has been put in place yet. The funding has not been issued. So it is not going to happen probably by January 2021. So we're going to continue doing as we have before, and we totally expect prescribers to continue to write prescriptions, fax them, phone them in, use electronics. It's going to be business as usual. This year, the prescription drug monitoring PDMP bill did not pass. It died at the end. It ran out of time the same way that it has in prior years. It passed the House. When it went to the Senate totally rewrote it and came up with their own version of a PDMP, and they passed that. The two bills didn't match, so they go to a conference committee, and the House has representatives and senators. They meet together and hammer out a final conference committee substitute that they will send out to both chambers. So they basically cut the PDMP down so that a committee would be formed, a task force would be formed to contract it out, and only doctors and pharmacists can see it. Nobody else can see it. Allow them to check on patients, and it would be paid for through a contract vendor to run it. When they sent that back to the House, it passed. They voted to accept that. When it went to the Senate, that's when they ran into some opposition. There was a few senators that still believed that it was unconstitutional. So at the end, it was withdrawn and did not get another vote. So that happened with like just a day or so left in the session. So maybe they'll be back to the drawing board next January on that. Senate Bill 523 by Representative and Pharmacist, or Senator, by Senator and Pharmacist Sater. He had some controlled drug bills out there. One of the things was to update the list of controlled substances, and that passed. We tried to keep it up to date by rule. The statute had not been updated for a couple of years. So he basically took our rule and updated it. So that'll be a more current list. But as we speak, the BNDD is drafting up a new rule because new drugs have come out. So we're always updating that. I'm not sure about House Bill 1486. When I look at House Bill 1486 that would have authorized needle exchange programs, that bill standing alone did not pass. What we don't know yet is did it get added in and combined with something else? So that bill individually shows that it didn't pass, but we have to scan everything else to make sure it wasn't added in. There's some other significant legislation that passed, but I'm going to get back to that later because it deals with some of our questions and some of the issues that we're dealing with. Updating regulations. We are updating a couple of our regulations that we are drafting on. Once again, we're updating the list of controlled drugs by rule. We are amending our registration requirement for EMS. This will have no impact at all on pharmacies, but instead of registering every single ambulance building at every single location, we're going to allow them to have one registration only at headquarters, and then they can move the drugs around to different buildings at different satellite sites as needed. So they're going to need just one BNDD number, one DEA number. Right now, I've got about 225 ambulance services, but they're at 500 locations. So this is going to let us reduce them down to just 225 registrations, and then they can move drugs around among their satellites. So we're working on that. I wanted to give a real quick refresher on Senate Bill 826 that passed a couple of years ago in 2018. This is that initial prescription for opiates, 7-day supply for new drugs. I'm going to fly through these pretty quick because there's just a couple of slides in here that are giving us questions from doctors and pharmacies. But for a thorough review of this, look at the newsletters. The Board of Pharmacy newsletter from August of 2018 is very good. The BNDD put it in their newsletter in October of 2018. So those are still out there and you can look at those. But this law applies to Missouri patients only living in Missouri. It does not apply to out-of-state patients, but all prescribers must comply if they are prescribing to a Missouri patient. This law applies to opiates and no other drugs. It does not apply to stimulants like methamphetamines, methylphenidate, Adderall, anything like that. It doesn't apply to benzos. So we get calls about that. It's for acute pain, and it's not for chronic pain. And they define acute pain, short period of time. It does not include chronic pain, cancer, hospice, end-of-life care, medication-assisted therapy for substance abuse disorders. So this is for new injuries, acute pain that's not going to be lasting that long. Initial prescription basically means that the patient has not had this drug for the last 5 months. We note that the language says drug. They didn't use the word opioid. So the patient may be receiving another opioid, but if you change drugs, that 7-day law applies. And I've got some examples that we'll talk about here in a little bit. But if a patient's been on Percocet for 3 months, and then all of a sudden the doctor changes them to hydrocodone, that's a new drug. The 7-day law applies because that's the way they wrote it. It doesn't matter what the strength is or the dosage form, but it's when the name of the drug changes. And we've got some scenarios. If the patient has not received that drug for 5 months, the initial prescription law applies. They're limited to 7 days or less. Example 2, if the patient's received hydromorphone for 2 months and the doctor reduces them down to hydrocodone, that's a new drug. If they haven't had that in 5 months, they only get a 7-day supply. A patient received oxycodone while in the hospital. When discharged, the doctor can prescribe them more than a 7-day supply because the patient just had that drug administered in the hospital. The patient receives a 10-day supply of codeine or hydrocodone cough syrup to treat a cough. That's allowed because that is not acute pain. It's for acute pain. Also, if they're being treated and they're going to get a 10-day supply of diphenoxylate to treat diarrhea, that's allowed because it's not an acute pain. If the patient's on hydrocodone for 2 months, the doctor wants to increase them to oxycodone, that's a new drug, so 7 days is all that can be authorized. How's a doctor or a pharmacist to know the patient's history? It's good faith effort. Show that you made a good faith effort. Talk with the patient, their caregivers. You can contact the prescriber, other pharmacies. Consult the St. Louis County PDMP if you're a member of that. Check their medical records. You can check cyber access for MoHealthNet data and any other actions that you deem to be appropriate in your professional judgment. So just a quick review, it's Missouri patients only, opiates only, for acute pain when they have not had that drug for 5 months. And then there's exceptions to that. It does not apply for people being treated for cancer palliative end-of-life care and hospice. It does not apply to long-term care facility residents, and it does not apply to those receiving buprenorphine for substance abuse disorder treatment. This law does not apply to veterinarians who are prescribing to animals. And then the big catch-all at the end, sometimes the doctor feels like in their best professional judgment, the patient actually needs a greater quantity. So they can exceed this as long as they document the reason in the medical record. So they can go over a 7-day supply if they feel it's in the best interest of the patient, and they're going to document that in the patient's chart. But we've been stressing to the doctors in all of our documents to them and our presentations to them, it's extremely important that they notify the pharmacies to let them know why, because the pharmacy is probably going to decline that prescription, and then they're going to call the doctor, and then they're going to have this discussion. So we're asking the doctors to do a lot more documentation on the prescription to let the pharmacist know what's going on. Some of the questions that we're being asked. The patient gets that brand new first-time prescription, but instead of 7 days, it's for 30 days. What do we do with that? What do we do with the remainder? Well, by law, they can only have 7 days. So the other 23 days is void. You can call the prescriber and let them know that due to the law, only 7 days could be dispensed and the remainder was void. So the patient only got a 7-day supply. The law states that the doctor can prescribe again and allow more after there has been a second consultation. So there has to be a second consultation in there before another prescription is issued. So you can dispense the first 7 days, the rest of it is void because they have to go back and get a consultation and a new prescription. And then it requires the doctors to provide patient education. When they issue that initial prescription, they have to consult with the patient, talk about options, lesser quantities, and risks that are associated with that drug. We also tell them to make sure you document that in a patient's chart. So that's some issues on that. A little bit about where we were with opioid abuse information. And this slide was prepared back in early March. So it was before we kind of got taken over by the COVID shutdown and everything like that. But you can see statistics that have crept up over the years in opioid related deaths, ER visits. We have the government grant to provide naloxone to the EMS, the police, the fire. They're administering that on the street. And how many lives have been saved, overdose reversals up to this point. This was a March 2020 number, that 1,543 we were able to revive. There's been a shift. The majority of deaths now involve street drugs involving fentanyl and carfentanil, illegal drug products that are smuggled in from overseas. The number of deaths from prescription pharmaceuticals has decreased. We want to remind everybody about your BNDD registration and when it is due. Everybody gets a registration for 1 year. It's a 1-year registration. We put the expiration date on there. We send out an email reminder 60 days in advance of your expiring to remind you that you're going to expire in 60 days. It's very critical that you give us a good email address that's provided on your application, because that's where your reminder is going to go. So if it goes to an office manager, a secretary, an administrative support person, and then they've left you or retired or resigned, then you may not get that email. So make sure that email goes somewhere that you get it. So keep your email addresses up to date. We have a lot of people also put their expiration dates on their calendar, their computer, their cell phone. They do that as an extra reminder. Some issues more current relating to the COVID-19 state of emergency. The governor has waived some sections of the statute regarding telemedicine. There's no requirement for that initial face-to-face physical exam. So they're allowed to communicate. They can talk on the phone, they're Skyping, they're teleconferencing, they're expanding telemedicine, but there's no need for a face-to-face exam at the beginning. All of the executive orders can be viewed online at the governor's website. And the BNDD has put some things out also allowing that telemedicine to happen. We've waived the, extended the annual inventory dates due to what we're going through right now, and patient care is most important. We have a lot of pharmacies that have chain stores or multiple stores, and their annual inventory was due, and that can take a lot of time. So we pushed that back and we extended it. Once the state of emergency has ended, you're going to get additional time out there after that to do your annual inventory. So we're going to extend that. The BNDD's waivers that our director has authorized and published and put out there on the websites, they are good and valid through the entire state of emergency until the governor declares the state of emergency is over. So we just didn't put an automatic stop date on them. They're open-ended and they're running and they're active until the governor says so. So we don't have any stop dates on that. Something else I'll go back here and talk about because it impacts everybody and us with COVID, but this is a time when healthcare providers are under a lot of pressure. We're operating under very difficult circumstances, trying to do the best we can to take care of patient care and safety. We don't feel this is the time for a BNDD inspector to show up on your doorstep, decide they want to come to your pharmacy and thumb through records. That is not a good idea. That's not conducive to what we're trying to accomplish. So for the past couple of months, the BNDD, we have not been going out and doing random routine inspections, visiting doctors' offices and pharmacies. And we're probably not going to do it for another month because due to the crisis and need for help, a lot of people in my entire department have been reassigned, and all the nurses and the inspectors are handling call centers, emergency hotlines. We're doing patient contract tracing. So everybody's busy working. They're just doing other things. BNDD will respond if we're called and asked to. We will respond if we get a complaint and we need to go in and get some records. But if you see a BNDD inspector come into your store, it'll be because we get a complaint on somebody and we need to get some type of records or something. But other than that, we are not going out and doing routine inspections at this time. If you need to contact us, please use our email because you're on the phone busy all day. We're on the phone busy all day. We don't want to play telephone tag. The best way to reach us is send us an email, and then we can look up the statute or the regulation, find out what it is, and send it right back to you. That'll be faster, and then you can spend more time with your patients. But we have all kinds of information out there. You can apply, make changes, review all of our documents, and we try to keep all that up to date. Some things that we are working on, we've got some short-term goals, some long-term goals that we're doing to become more efficient. As an entire division, we are working on a new online application database system so that people can apply online and get registrations and licenses easier. And this will be for everybody: hospital licensing, nursing homes, surgery centers, and BNDD. So it's going to take some time. We're going to get the funding, we're going to build it, but that's in the pipeline. Something better than that now, We are scanning in our applications and saving them electronically to eliminate paper. BNDD has almost 33,000 registrants. 95% of them apply online, click to pay with a credit card. It's paperless. We issue about 95% of those registrations in 24 hours. They only get held up if they're incomplete or more documents are needed, or there's a problem with the credit card, or if there's a complaint, an open investigation. But we can say basically that 95% of all BNDD registrants can get a registration in 24 hours. It just depends on if you apply on a Friday or on a Monday or whatever. It takes one business day. The 5% of the people that apply online and send in paper, it takes a couple of weeks because we're waiting on the mail. It gets to the mailing center, it comes to the department, it goes to fee receipt. It might be a week before BNDD even sees the application. Then it has to be hand entered and then issued. So when you apply with us, just know that if you apply online, it's going to take a day or so. If you apply on paper, it could take weeks. And then the other thing that we're working on is our lost theft diversion reporting form. Right now, people go online, fill out a form, send it in paper. We get emails, faxes, we get them in the mail. We want to go paperless on that and go electronic so that people can go to a website, fill in the blanks, type it in and hit submit. It's going to go to a database. We can search it, query it, share information with the boards, and we want to go paperless on that. And we've got grant money funding to do that. And we've picked the software and the database and how we're going to do it. It's just a matter of getting everybody back to work and getting the IT folks to help program it for us. Available resources out there, there's contact information. If anybody has any questions and wants to know how to contact us or anything like that, nothing's changed. You can go to Google and type in BNDD and we'll be the first thing that pops up because we get more hits than anybody on that. That's all I have on the slides. I think we're ready to go to questions.
Okay, so like I said, we're going to take questions that were submitted in advance first, but you can still submit, if you have a question, you can submit it to us using the toolbar if you'd like to send us some. Okay, so the ones that came in advance, I kind of sorted them into different topics, so we'll try to stay on topic for most of these. So the first groups deal with prescription dispensing questions. So we have someone asking, what is the rule on C2 prescriptions that have a sticker with the patient information on them that typically, like at a hospital, gets applied to it? Is that a legitimate prescription?
We get that question a lot, and I refer to the DEA regulation because I discussed this with the DEA policy people, and their instruction to me has been that the DEA federal regulation requires that prescriptions are written or printed in indelible ink or pencil, and they can be printed directly or typed onto the prescription, but the regulation does not allow stickers. Stickers can be easily removed, stickers altered, stickers replaced, different information put on there. And then we also find out when we go into pharmacy, sometimes those stickers dry out and fall off the prescriptions. So then we've got a prescription there and we don't have all the information on the face of it, but we've got a bunch of dried up stickers at the bottom of the drawer. But anyway, the DEA has told us no on the stickers.
Okay, we have someone asking, when a patient presents a prescription for themselves for a controlled substance, can they use an expired photo ID?
Okay, and I've got a note here on my paper here because it's going to allow me to backtrack and talk about something else. But first of all, the BNDD does not have a law or a regulation that requires a photo ID to pick up a prescription. So we really can't say, does it have to be a driver's license, a state ID, a work ID? Does it have to be current? Does it have to be expired? We don't have a law on that. We don't require any photo ID to pick up a prescription. So basically, I think the pharmacies are setting their own policy of whether you want somebody to show an ID when they pick up a prescription. Now, it's different for Sudafed. When a customer comes in and wants to buy Sudafed over the counter, you got to put them in the database. That law requires a current valid state ID of some type, whether it be a driver's license, a state ID, and that's got to be current. So it's no ID on prescriptions, but it's yes, ID required for Sudafed. And while we're talking about Sudafed, hot off the press here, last Friday, the legislature changed the Sudafed dispensing law in the state of Missouri. For those of you who would like to read it, it's House Bill 1896, House Bill 1896. That's a big bill. It's going to be a lot of pages, but you scroll down until you can see our section 195.417. That's section 195.417 on Sudafed dispensing. And here's the changes that they made in the Missouri Sudafed law. Instead of allowing 9 grams a month, they cut it back to 7 grams a month. They also said that a person could only receive 43 grams in a calendar year. So they put that in there. And then the big change, they put in there that no local city, county, or local jurisdiction can pass an ordinance that requires and mandates a prescription. So it's taking all of those. I think BNDD has a list. There's 64 cities and counties out there that have a local ordinance that says prescription only, no Sudafed is sold unless you have a prescription. Well, that's going to be voided on August 28th of this year. The legislature has said that pharmacies can sell Sudafed over the counter. They can put the sales into the NPLEX database system, and patients no longer have to go see a practitioner and get a prescription. So that means that if you're a pharmacy in one of those 64 jurisdictions that mandates a prescription, you're going to stop doing that, and you're going to have to enroll in the NPLEX database system that's ran by our state vendor, APRIS. So as soon as we can here in the next month or so, BNDD is going to put out a big information blurb on our website, and we're going to share it with the board and give you information on how to contact them, how to enroll, how to bring your pharmacy online, and how to do that. But you've got until August 28th to do that. Keep in mind that prescriptions are not required, but there are times when a prescription could be used and it would be okay. Hospice patients aren't going to be able to walk into your pharmacy. Their doctors might want to write them a prescription. There are times when a doctor wants a patient to have more, they can write a prescription. Long-term care residents aren't going to walk into a pharmacy. They get their medicine by prescription. So the statute says may in there. They can get their drugs without a prescription. So we're going to continue to fill prescriptions for nursing homes, hospice, people like that. But for the ambulatory customer coming in the door, they're not going to have to get a prescription anymore.
Just to clarify, Mike, the governor hasn't signed that bill yet.
Right,
so.
that has not been signed.
Okay. Let's see. We have some questions about partial filling of C2 prescriptions. So I'm a long-term care pharmacy. Can I still partial fill a C2 prescription for 60 days from the issue date for the long-term care patient?
The Missouri regulation currently says 30 days. When we originally drafted that, we wanted to match the DEA federal law and go with 60 days. But other agencies, long-term care, Section for Long-Term Care, they have industry regulations they require all nursing home, long-term care, patient medical records, and medication orders to be reviewed, updated every 30 days. So when they came out with the rule, they went with 30 days. So the Missouri regulation allows that partial dispensing for 30 days, not the 60.
So based on that, we have some people asking about out-of-state long-term care facilities and out-of-state prescribers. Does the 30 days apply to a patient in a long-term care facility located outside of Missouri?
It applies to you and where your pharmacy is. If you are a pharmacist and your pharmacy and you're in the state of Missouri, you have to follow that 30-day rule. Because you can only dispense and you're inside the state of Missouri, you're limited to the 30 days.
And so the follow-up to that was, and that would apply to the prescriber being out of state also, it wouldn't matter.
Yes.
This one, if a prescriber issues 3 30-day C2 prescriptions for a total of 90 days, is only the first of the 3 prescriptions allowed to be partial filled?
Yes, they're all separate prescriptions. In our Schedule II world, there are no refills. So every prescription is a new one. Each prescription is separate. So the first prescription can be partially dispensed for 30 days. The second prescription can do that. The third prescription can do that.
Can a Missouri pharmacy fill a 30-day supply of a C2 ADHD medication written by a mid-level practitioner in Kansas, even though Missouri mid-level practitioners do not have that authority?
Yes, you fill those prescriptions based upon the home state of where the practitioner is. In Kansas, those mid-level practitioners have a full DEA number with full prescribing authority with no restrictions, so they can write more than a 30-day supply. They don't have the restrictions that have been put on the Missouri nurses. So you can fill those as what Kansas law allows them.
And follow up to that, they're asking, does that same apply to a 30-day supply of a hydrocodone product, which in Missouri, the practitioner would be limited to 5 days?
Yes, it does. It applies. They can certainly fill that prescription. So you might see Kansas nurses writing for oxycodone or morphine or something like that. And yes, those can be filled.
Okay, we have some about collaborating for physicians. Does the physician's name, the collaborating physician's name required to be on the label of all controlled substance prescriptions in Missouri for mid-level practitioners?
It is required to be put on the label of every controlled drug dispensed by a Missouri pharmacy in the state of Missouri, no matter where the mid-level practitioner is from, because the legislature put that requirement in your bottle labeling law. In that section, when they tell the pharmacist what goes on your pharmacy label when you dispense, they put the collaborating name of the physician, goes on the label every time in every bottle in Missouri pharmacies. So that's going to apply to all mid-levels regardless of what state they come from.
So another one about collaborating physicians. If the collaborating physician is not listed on the prescription, including an e-prescription, can I call and obtain that from the physician or the nurse practitioner?
Yes, you can. Anytime there's something that's incomplete, you can call, add that information, document that you did it, as long as you're not changing the patient's name, the doctor's name, or the entire drug, but you can change everything else.
So we have a scenario of 3 electronic prescriptions issued on the same day for the same patient for Adderall. None of the 3 e-prescriptions contain a do not fill before date. Do each of the 3 prescriptions need to have one? And can I call the prescriber to get that?
Yes, you can. If there should be do not fill until dates, you can call, ask what that is, and add it. If they need to be updated, changed, That's changes you can make after you've called the doctor.
Can a prescriber's agent fax a C2 prescription to a long-term care facility and then a representative of the long-term care facility then fax it to the pharmacy? Or must it come directly from the prescriber or their agent to the pharmacy?
Okay, first of all, we're talking about faxing. So the first thing that has to happen is on a fax, the prescriber, the doctor, has to actually write a legal prescription that has all the elements on it. Before it's even faxed, there has to be a complete prescription that's got the patient's name and address, the date, drug name, strength, form, and quantity, DEA number. Everything has to be on there that's required. The doctor has to sign it in ink. Now, after the doctor has written the prescription, then it can be faxed by any of his agents. And that can be a co-worker, an employee in the doctor's office. And that extends to the staff in the nursing home. The nurses and the staff in a nursing home are recognized as being agents of the doctor, because usually that's their medical director. They're providing patient care to a person that's in that licensed facility. So nursing home staff can send faxes of prescriptions to the pharmacy, but the doctor has to have signed them first, then they fax them.
So now we got some on, let's see, it's like the opioid 7-day rule. If a prescription for tramadol was written for a 30-day supply with 2 refills, but the patient is limited to a 7-day initial supply based on Missouri law, what happens to the remaining quantity and the refills?
Yeah, we just covered that earlier. You fill the first initial 7 days, and then the rest of it is voided. They're gonna have to let the doctor know that the rest of it was voided. The patient's only getting 7 days, and there can be a new prescription written after there's been a second consultation.
Follow up to that, they want to know if the limit is, the 7-day limit is not based on Missouri law, but by an insurance limit, does that still mean it's voided?
Yeah, yes, we would go with that, because they're not gonna authorize it.
So here's a question combining multiple scripts in this 7-day. If a doctor writes 3 prescriptions for a C2 drug on the same day, each for 30-day supply, with our prescriptions 2 and 3 stating do not fill, and the pharmacist determines that this is an acute opioid treatment with no prior use and has to limit it to 7 days on the first one, what happens to prescriptions 2 and 3?
Yeah, they're voided, because if it's that initial prescription for a new opiate, they're limited to 7 days. So the doctor should not even written prescriptions number 2 and number 3. There has to be a second consultation in there.
And then I believe we get this every time you're here, Mike. Questions on testosterone dispensing when the vial size is larger than the 90-day supply limit.
The Missouri legislature statute limits a 90-day supply to all controlled drugs in all situations. There are no exceptions. So a 90-day supply is all that can be dispensed. So the doctor has choices. The doctor can change the amount and quantity and frequency, or the doctor can buy the drug and stock it themselves and keep it in their office and administer it themselves as needed. The pharmacies could draw it up and repackage it and relabel it if they have a sterile compounding permit.
Correct. They would need Class H in order to do that. Got some questions on e-prescribing. With mandatory e-prescribing taking effect in January, will I still be able to fill a controlled substance prescription I receive that is not e-prescribed?
Yes, and we covered that. and we want the pharmacies to continue business as usual. Don't stop what you're doing. We're going to continue to see prescriptions faxed, telephoned, handwritten. Keep doing what you're doing.
If on e-prescriptions, if the doctor or patient has a PO box, not an address, do we reject the prescription?
Yes, you would reject it because no prescription is valid unless it shows the address of the prescriber and the patient. A PO box is just their mailing address. It's where they choose to get mail. It doesn't tell you the address of where they live. A post office box is going to be in a post office somewhere. That is not their address. So they have to have a physical address.
Got some questions on data wave prescribing. Can you prescribe Suboxone and Subutex for pain? And if so, do you need the XDEA number in order to do that?
Subutex and Suboxone can be prescribed for pain, and no X is required for the treatment of pain management. You only need an X if you're doing chemical dependency and drug abuse treatment.
A couple questions on annual inventories. How should a pharmacy handle a leap year when you're doing, if it falls on your inventory date?
The law says annual inventory. It says do an annual inventory at least once a year. You can pick the day. So regardless of what day it falls on, no matter what day you did it, just make sure that at all times when you look at your annual inventory document, it's not more than 365 days old. So you can do it days before, things like that. Just don't let your annual inventory become more than 365 days old. But right now, you know, we have a waiver on that because of our current emergency.
If a pharmacy maintains a perpetual inventory, do you still have to do an annual inventory?
Yes, because an annual inventory is a standalone document. It's something that you do once a year, and then it's printed out and it's saved, and it has to be on paper. It's something you print it and save it because that's where you staple and attach and file your insignificant losses. If something is broken, leakage, spillage, if you have to explain what happened to a drug that was insignificantly lost, the regulation says to attach that to your annual inventory document.
The next questions deal with losses. So when is a loss report required to be submitted and when is it not required? We're talking about BNDD loss report.
Right, BNDD law is different than DEA law. BNDD asks more questions and has some different reporting guidelines. A report is required when there is any drug amount that is lost, stolen, or diverted. We cover diversion in our regulation. Loss means it's missing and you don't know where it went. You're looking around, you have no idea what happened to it, it's lost. Then you do a loss report. Stolen, of course, you know what that means. There was a theft, somebody took it without paying for it, you had a burglary, you had an armed robbery. If it's stolen, it's stolen. Diversion is when drugs leave their authorized and legal channels and enter into any path that's not allowed by law. So if drugs are diverted, you report that. Now, let me give you a detailed example of a case that we had happen. We had a pharmacy technician who was making up false prescriptions, putting them in the computer, but then would pay for them. So everything balanced. The records balanced, the drug count balanced, the prescriptions were there. There was no money missing. Later on down the road when they got caught, they confessed and told the pharmacy manager what they had been doing. And they had a list of the prescriptions. the pharmacist knew what had happened to those drugs and exactly where they went. So they weren't lost. Well, they weren't stolen because the guy paid for them. So he did not report that to the DEA, because the DEA only wants you to report drugs that are lost or stolen. And these drugs, they knew where they went and they weren't stolen, they were paid for. So they did not report that to the DEA. But BNDD makes you report diversion and illegal activity. So they did report it to us. So we have that. Also, we want to cover what does not get reported. And we define this in our rule. But you do not report insignificant losses. And that is not defined by a quantity, like under 1 tablet or under 10 milliliters. Insignificant losses are things that happen when you lose drugs due to daily normal activities, and certain things happen. You have breakage, you spill it, you're compounding and a batch doesn't turn out right. You need to destroy it and start over. If somebody drops a pill and somebody steps on it, in these cases, the drugs were not lost, they weren't stolen, they weren't diverted, there was no illegal activity. But you just need a way of writing it down and documenting what happened so your records balance. That's what's considered an insignificant event. You write that down on a piece of paper and you staple it, you attach it, you file it in your annual inventory document. And you don't have to report those to us. They just get attached to your annual inventory.
When do I need to send a corrected or amended loss report to BNDD? And how is that done?
Okay. You would need to send us an amended corrected report anytime you realize that the first one had an error on it. So if you do a loss report and then later on down the road, after a more detailed audit, you find out more information, the numbers are different, you can amend it. Just fill out the form again, or take the other form you sent in, but you can write across the top of it. We have a lot of pharmacies do this, and it's helpful to us. They'll send in a loss report and they'll write across the top of it, initial notice or initial report only. And then they might write final report. And if you need to amend it, just write amended report. That lets us know that you've sent it in before, but now you're changing something. So you can just write amended on it. And then you send it to us the same way you always would. You can email it, fax it, mail it.
Can you provide some of the trends that you're seeing in losses from pharmacies?
We are getting a total of an average, we're getting 200 loss reports a month. That's from everybody. Hospitals, pharmacies, doctors, distributors, whatever. But we're getting about 200 a month or 2,400 a year. The majority are lost in transit. If you're in the mail order business, something happens between one point and another. We see a lot of bottles that are open from manufacturers or distributors, and they're missing one tablet. They're one tablet short. Or a bottle doesn't make it from this warehouse to this building. We see a lot of lost in transit. Much smaller quantities are lost when you're a tablet short in a stock bottle, or there's something lost in transit. As far as illegal diversion by illegal activity, our number one source is, of course, the registered technicians. They have access to the safe. They can get in the system and maybe change numbers. They're stealing up until they get caught. But the biggest number of diversion in pharmacy is still with technicians.
I have a question about waste and destruction. What is the proper way to waste controlled substance? And they gave some examples of broken pills, expired controlled substances, compounded controlled substances, and partial syringes.
Okay, we can help you with that and tell you what we do. The BNDD website has, under its educational publications, some documents on how to destroy drugs. The DEA has information on that on their website. So does the Department of Natural Resources. And I can tell you what the BNDD does, because we seize a lot of stuff and destroy it. The drugs need to be destroyed beyond reclamation so that nobody can come along behind you and dig them out of the trash and abuse them. We want them to be destroyed and unsuitable. Do it with 2 people, document it. If they're pills or tablets or capsules, I put them in a plastic container, a coffee jug, a milk jug. I put them in some kind of a plastic container and mix it with bleach or ammonia or something caustic like that. Now, I don't use both, but I tend to use bleach. I'll dump bottles into a plastic container and fill it up with bleach, duct tape it shut, throw it in the trash. It can be discarded then. If they are glass vials, I put them in a Ziploc bag, beat them with a hammer. It mixes with powdered glass, and then I'll throw in some bleach. And then I dispose of it, put it in the trash. It'll go out in the dumpster. It's in an unmarked bag. Nobody knows what's in there. And if they want to take the time to go through our dumpster and find a plastic bag full of powdered glass and drug that's had bleach in it, but that's what we do. Also, expired controlled drugs that are still in stock bottles, you can destroy those on site now also yourself. They want you to execute and use the DEA Form 41. The DEA has a form for that. We have that in our bureau. If you email it to me, I can send it to you, because you have such bulk, and it would be time consuming. A lot of pharmacies reverse distribute, which is fine. You can do that. But if you want to destroy some, I can send you a DEA Form 41. You can destroy on site. It's done by 2 people. You fill it out and you keep the form there yourself on file.
I'll take a couple more here. This is for a hospital resident writing a controlled substance. Do they have to have their collaborating doctor and their collaborating doctor's DEA number listed on the prescription as well?
The state law says that mid-level practitioners with collaborating doctors have to have that information on the bottle. Resident physicians normally don't. They are doctors. They have a medical degree. They're residents in training, and they write their own prescriptions, have a BNDD number. They use the hospital's DEA number. I'm not sure if resident physicians in training are even in a collaborative practice agreement. So I would say that resident physicians do not have to have a collaborating doctor's name on it, but mid-level practitioners do.
And we'll take one more. Does Missouri plan to delist Epidiolex since the DEA descheduled it?
Yes, and we've already taken some initial steps to do that. Epidiolex, which is our nation's first CBD approved medication for the treatment of epilepsy, that's Schedule 5. The DEA scheduled it, so we scheduled it. Well, now the DEA has descheduled it, so the BNDD is going to deschedule it. We're going to follow suit and do the same thing. Now, the issue is getting a Missouri regulation updated, going through the steps takes about 9 months. But in the meantime, we've put out documentation that we're going to allow Missouri pharmacies to go ahead and treat it like it's not controlled. Follow the DEA guideline. I sent a letter to the manufacturer and to their lobbyist, and I sent it to the Missouri Pharmacy Association to put out. I wanted to let them know that the DEA descheduled Epidiolex. BNDD is going to do it also, but in the meantime, go ahead and treat it like it's non-controlled.
Okay. We did not get to all our questions that were submitted during the webinar. If you would like, you could email that to bndd@health.mo.gov. If we didn't answer your question and you'd like Mike to send you an answer. So before I close, next webinar, final one, we know on August 8th, we'll have our legislative update, and on September 17th, we'll have a compliance and question and answer session. I'm still trying to reschedule our the one we postponed with Mo Health Net. I believe we will have that later this summer. So watch for email alerts on when we'll have those registrations open. As I said, we do record all our webinars. We've had some already this year that's on our website. I did a regulation update in February, and then we did 2 different COVID-19 updates. All 3 of those are on our website. So for continuing education, in order to get it, you must answer the survey that comes up at the end of the program. So do not close your browser. When I say I'm going to close the webinar, a little window pops up that tells you that I've ended it. You need to click close on that. And then again, do not close your browser, and a survey should open up automatically on your screen. Answer the questions and click submit. If you do not get the questions, they do not open up. We do know sometimes that people on mobile devices and tablets doesn't always work properly. You can send an email to compliance@pr.mo.gov, and we'll send you the questions, and you can answer them by email, but we must have them back within 24 hours in order for you to get CE. Again, we will mail out certificates in approximately 30 days. So again, thanks, Mike, for coming today. We really appreciate you taking the time to come speak to all our licensees. So I'm going to end the webinar now.